Yeah.
Okay.
You can start.
Oh, sure. Thank you.
So Reuben, let me maybe just introduce you guys. I'll just introduce you shortly, and then you can start. So, welcome everyone to this sort of monthly interesting EP cases webinar, and it's today two people I know very well. Reuben Mutagaywa, who's currently doing his EP fellowship with Professor John Roshan in Christian Medical College, India. I know Reuben, he was a Pascoe Fellow here in Cape Town, and John and I sort of trained in different centers in Canada around about the same time. So it's I'm looking really forward to this interesting case, which looks very cryptic from the title, but I'm sure we'll soon find out what you're going to be speaking on. So thanks, Reuben. Thanks for talking today.
Thank you so much. So, first of all, I would like to express my sincere thanks to CMC Vellore, especially Head of Cardiology Unit, Professor John Roshan, for accepting an invitation from AFHRA to bring this case discussion forward. But again, we will be presenting a patient whom we recently treated under leadership of Dr. Sirish Chandra here at Vellore with his team. So we also appreciate him accepting also to have this case being presented. Next slide. So this is a patient, a 62-year-old female, who presented to us with history of palpitations for the past 3 years. That was recurrent and on and off. She is diabetic type 2 and hypertensive on regular treatment and with controlled values. She previously did the echo and laboratory tests, which were normal. Next. So when we saw her tachycardia ECG that was done elsewhere in the periphery, it is a regular narrow complex tachycardia with
we don't see the ECG, Reuben.
You don't
the first slide has not changed.
We can see the ECG, Vilbert.
Okay, so it is my okay. It's okay. It's the internet connection in my phone. No problem.
Okay, good that you saw it. So it's a regular narrow complex tachycardia. There's no obvious pseudo ARA in V1 and pseudo S in lead 2, which are mostly seen with the typical AVNRT. So probably we are dealing with either atrial tachycardia, atypical AVNRT, or AVRT. But also,
can everyone mute their mics, please? Can everyone mute their mics?
Actually, mute him. You can do this. Actually, you can do it because you are the host.
By 9, I will send that.
Okay, let me just see how to do that.
Go to the name and mute. And touch the microphone.
يا حبيبتي ليش كل ساعة تأجين كل شيء ليش؟
السلام عليكم السلام عليكم يا رنا اللي بيتكلم please who talks mute your microphones please everybody.
Mute your mic, man. You're speaking earlier.
Okay.
And yes, so I'm unmuted because I'm speaking.
But we lost your slides. Are there?
Yeah, slides are there. Can you go next slide, John, sir?
Yeah, you want me to go forwards, Reuben?
Yes. I have described this narrow complex tachycardia already. It's a short therapy tachycardia with probably AVRT, a typical AVRT, or a atrial tachycardia or differential. So we also saw a sinus rhythm ECG, which does not show much, but probably there is a subtle broad QRS. Otherwise, no evidence of pre-excitation, and that's the only message you can get from this sinus rhythm ECG. Next. So with that history and ECG findings, we posted this patient for electrophysiology study with the mind of ablating if we got the problem, we find the disease. And this slide shows catheter positions, the 4 catheters, as you can appreciate. Next. In the lab, baseline surface ECG showed a narrow sinus rhythm, narrow complex of 101 milliseconds. Next. And baseline EGM, there was no more intervals except for a slightly short HV intervals, but other baseline EGM intervals were normal. Next. So we went on to do assessing retrograde conduction by starting with the burst right ventricular pacing. And as you can see, we have a 1-to-1 VA conduction at up to rate of 470. Next. We measured the VA interval and found it to be 146 milliseconds, and the earliest auto activation was from CS56, as you can see. So it's from the septal region. Next. Another observation at pacing rate of 340, we had a conduction of 2-to-1 with also earliest auto activation from C56. Next. But at this juncture, we measured the VA interval and found it to be 99 milliseconds. And again, with a 2-to-1 block, 2-to-1 conduction, and also CS56 as earliest auto activation. Next. So as you can see, we have 2 findings which probably needs to be explained because it is not expected. Of course, it's not it's a non-decremental conduction, but again, the response is not one would expect at a rate of 480 and rate of 340. If there is anyone among us who is a fellow can respond to what is going on.
So just to paraphrase Reuben's question, what Reuben is trying to say is that we have been ventricular pacing at 480 and we had a VA time of 146, and then you're pacing at a faster rate of 340 and you're having a VA time of 99. So the paradox that Reuben is facing is that at pacing with a faster rate, he's having a shorter VA interval as against when pacing at a slower rate. As we know, in the heart, tissues tend to decrement when you pace at faster rates, particularly when you're going up from the ventricle to the atrium via the AV node. So you would expect the VA time to prolong when you pace at faster rates. So on pacing at 340 milliseconds, Reuben expects the VA to be longer than 146 milliseconds, if not at least the same. But here he finds the VA time is shorter when he's pacing at 340 as against 480. So he's now requesting if you can help him understand this paradox that he's faced with.
Anyone among us?
Hi, good afternoon. I'm just gonna try and switch my camera on. My name is C. I'm one of the EP fellows under Professor Chin. So it looks like here you might have decremented the AV node and probably have conduction maybe via an accessory pathway which is close to the AV node, because again your earliest activation also becomes, I think the His there is activated early as well. So that is what I would think this is as a potential cause.
Thank you so much for your response, see. So what we are looking at is here you're having pacing at 480, which is a slower rate, and you can see the atrial activation pattern over here. And here you're pacing at a faster rate, and here the atrial activation pattern looks a little different from what it was over here. So you were proposing that there could be some AV nodal conduction involved, as well as some pathway conduction involved, which could explain why it looks different. But even if we involved an AV node and a pathway, the question is, why is it that when you pace at a slower rate, it is longer, whereas at a faster rate, it is shorter? So if you're saying at a faster rate, it's shorter because a pathway conducted, then what was the pathway doing here? Why wasn't it conducting here? So I think Reuben will help us as we continue with the further slides.
Yes, thank you, fellow from Cape Town, for a nice trial. I think it was a good response, but also, as Professor Roshan said, probably we have other explanation of this finding. So next slide. Again, we did a programmed electrical stimulation, and we found relatively similar observation from what we got during burst RV pacing. But here, there is a slight of VA jump, as you can see, at a pacing rate of 290 with the decrement of 10 milliseconds. There is really a prolongation of VA time. So similar observation, but here is slightly a VA jump is seen. Next. Now, with those findings, we thought there's something in dealing with conduction throughout from ventricle to atrium, and we wanted to look what could be that in terms of septal accessory pathway or conduction up via AV node. And therefore, we went on to do para-Hessian pacing in attempt to get what could be the which is going on. Next. So as you can see, we had these different QRS morphologies, 4 in this bit, and as you can see, I want you to concentrate on the mid of bits, the second and third one. Second one looks broader, and the third one looks narrowish, and therefore this will inform us something. Next. You know, with para-Hessian pacing from that illustration on the left side, if you are capturing this alone, you have a narrow QRS complex, but VA time should be similar, whether you are capturing ventricle and His or His alone, because of the presence of accessory pathway, you'll have a stimulus to atrial time or interval similar, but the QRS morphology will be different. With His capture alone, it will be narrowish because you are taking a shorter route, but with shorter time to reach the atrium. But with V with His, you will be kind of traveling in a longer kind of route. So you have a broader QRS complex. Next. So let's go back to our two morphologies, the broad and the narrow. So one would expect next. One would expect the broader one to be RV capture and the narrower one to be RV with his capture from the schematic presentation which I just showed you. Next. We went on and measured the stimulus to, the VA time, which is also stimulus to actual time. And we found that with the broader morphology, we had a shorter VA time of 99 milliseconds. And with the narrowish one, we had a longer VA time of, as you can see, something which is not expected. If it was a pathway, one would expect to have a slightly similar VA time because of the duration which is taken from where you are passing to the atrium through the accessory pathway. So this again does not conform to what we expected in terms of accessory pathway. But could it be AV nodal conduction? Because with parallel pacing, one want to see the conduction, whether it's through the accessory pathway or through the AV node. So if it was a V node or node response, the reverse could be true. You expected the first bit to have a longer VA time again because of the broader, but now it's a shorter VA time. So again, it cannot be a AV node response. So there are still possibilities of accessory pathway response rather than AV node response. And we will get the answer in the next slide.
So just to reiterate the point Dr. Reuben was making, he was saying that you've got a broad beat here and a narrow beat here when you're doing para-Hessian pacing. The broad beat is usually due to ventricular capture, and the narrow beat is usually due to ventricle and his capture, which is why you have the narrower beat. And when you have a pathway, the VA time should be the same. Here, we don't find the VA times being same. So it is not like what you would get when you have a pathway. But then when you have a broader beat, and if it is AV nodal conduction, then the VA time should be longer with a broader beat than with a narrow beat. Because when you pace the ventricle, the impulse has to travel all the way up the AV node and up the bundle of His and the AV node to go up to the A. So it contributes to a longer VA time, as against a narrower beat where you capture the His and the V. So you will climb up much shorter. You just have to travel from the His to the A, as against here where you have to travel from the V to the A. So if it was nodal conduction and you had a broader beat, this VA should be longer than this VA. But the paradox that Reuben is faced with is that his broader beat is having a shorter VA time as against the narrower beat. So he's now trying to explain why he's got this paradoxical response when attempting to do para-Hessian pacing.
Yes, and probably what is being captured in this sense? Because we ruled out a V node from those findings, but by critical analyzing and further looking of what we capture, you can clearly see that with the first bit, which was broader, we are having an isoelectric time which is shorter, 2 milliseconds. And also, the local V comes a bit early, while on the bit which was looking narrower, we have a bit of longer isoelectric time of 41 milliseconds, and the local V comes late. So this could explain what we were seeing in terms of what we have captured. Next. Now we will change our mind and label them as first bit was RV capture alone, and second one was selective His capture. So this could explain the paradox which we were seeing as from the last slide. Next. So we are taking short time with the first bit and longer time or delayed time when you capture his and the RV. I mean, when you selectively capture his. Again, we had this paradox which we presented during burst RV pacing, that we saw a longer VA time during pacing at a rate of 480 and shorter during pacing at a rate of 340. But it seems that we were capturing these structures when we are doing this burst RV pacing in the beginning. So again, similar explanation could be given to what we saw. Next.
Can you elaborate
So
on that, Reuben? That probably just, can you go back and elaborate on that for everybody to understand better?
Yes. So as we say that this was being seen as a paradox, but this paradox can be explained by what we are being capturing, that in the first instance, we were capturing his alone at a rate of 480. And at a rate of 340, we captured RV alone. Maybe if there is additional, but that is what I'm able to tell.
I think
what
the
kind
point
of response do you think?
Yeah, I think the point Sirish was asking was, why did you say that this was only his, and why did you say that this was RV? And what is the response you're getting in each of these situations in terms of the atrial activation?
Maybe the previous slide, can you go back and, because that's the important part. Yeah. So what kind of response, if you decide that this is RV and this is selective his, suggest?
Okay.
Yeah, probably Dr. John can explain for the audience.
Yeah, so I think the point that Reuben was trying to make was that when you have a narrow beat and a broader beat, and you look very carefully to see what is being captured in each of these situations, you see this clear isoelectric line coming after this paced beat. So when you have a clear isoelectric line coming, it means that you have not captured the ventricle. Because if you capture the ventricle, then immediately you should start seeing the QRS starting off. But here you've captured some other structure that is insulated from the ventricle. So this is a selective His capture, which is why we have this isoelectric period, which is the time taken for the impulse to travel down the His bundle, the bundle branches, the Purkinje fibers to exit into the V, after which you start seeing this QRS. So this beat is selective His capture, which we are comparing with another beat here. And here you have the pacing spike, and soon after the pacing spike, you see the QRS. So this is a RV capture. So you have ventricular capture over here, whereas here you have selective His capture. So now, because you have selective His capture over here and you have ventricular capture over here, hence you have a difference in your VA times. Because here you have to go from the His bundle up the AV node, and then you activate the atrium. So your AV node, as we know, has got decremental property. So it takes time to go from there all the way to the A. Whereas over here, you're pacing the ventricle directly, and if there is an accessory pathway, you can climb up immediately to the atrium. The next thing is to look at the activation sequence of the atrium, and you can see that there's a subtle difference in the activation sequence over here versus over here. Here you can see that your CS56 seems to be early, whereas here CS910 is earlier than CS56. So clearly here, the impulse is going up the AV node. You capture the His bundle, it's traveling through the AV node, takes time to go through the AV node and then give the atrial activation sequence, which is a concentric activation sequence starting earliest in 910 and then going off to CS12. Whereas here, you're pacing the ventricle and you are not going up the node, whereas you're immediately going up an accessory pathway, which is why you have a short VA time and your atrial activation sequence is eccentric with CS56 being activated early. So when we look at the trace, we are actually not sure what we're dealing with. We are just seeing broad beats and narrow beats. And when you see broad beats and narrow beats, we assume that the broad beat is RV and the narrow beat is RV plus his. But then it's important to see what you have captured in each of these cases. And the moment you see that there's an isoelectric segment over here, it cannot be RV capture at all. And the moment you realize that there's an isoelectric segment, it means that you've captured the his alone. So this is a pure his capture, which is being compared with an RV capture. And you see a difference in the atrial activation sequence, which means the impulse is going up to the A through different routes. It's not going to the A the same way. And in the broader beat, you have the earliest activation, which is eccentric. So this has to be a pathway conduction. The narrower beat, you have a concentric conduction, most probably going up the AV node. And because of the AV nodal decrement, you have a longer VA time here as against here, which is a shorter VA time. So now the point Reuben was trying to make was that he was using the same thing to explain the paradox that we faced earlier. So earlier we had a situation where we were pacing slowly and then we were pacing fast. And when you pace faster, you always expect decrement to happen. If it is going up the AV node, you expect the VA time to prolong. But to Reuben's surprise, when he was pacing faster at 340 milliseconds, he found his VA time was shorter. It was 99. Whereas when he was pacing slower, his VA time was longer. Now again, Reuben looks carefully at what he has captured in each of these beats, and he finds that when he was pacing slower, he has an isoelectric interval over here, which means he was not capturing the ventricle here. He was capturing the his bundle over here, and the impulse was traveling after capturing the his bundle to the V and the A. Whereas here, he was capturing, you can see the QRS starting straight off. So there is capture of the ventricular myocardium over here. And once you capture the ventricular myocardium, if you have an accessory pathway, you'll go up straight to through the accessory pathway to the A. So you have a shorter VA time because you're going from the V to the A up an accessory pathway over here. Whereas here, because it's selective his capture, it has to take time to reach the pathway. So the impulse will go through the AV node to the A, simultaneously go down to the V, and then have to travel through the pathway to go to the A. So it takes time for it to reach the pathway. So automatically your VA time gets long, because if it's going through the AV node, decrement is going to cause longer VA time. Even if it has to reach the pathway, it has to take a long time, because it can reach the pathway only by exiting the V and then traveling up to reach the site where the pathway is located. So you have a longer VA time here when you have his capture. You have a shorter VA time when you have pure RV capture, is the point that Reuben was trying to make. He was trying to stress that when we have such responses, it's important for us to see what we have captured. The moment you see an isoelectric segment after a ventricular pacing, you should realize that you haven't actually captured the V. You've captured something else which has subsequently activated the V, and that is most likely the his, which is the insulated structure, and hence you have this isoelectric interval. Sirish, anything that I missed?
Yeah, no, nothing.
Thank you for elaboration and illustration. Next slide. So lately we demonstrate that this pathway is located on the septal region, as you can see from AFHRA activation sequencing. Next slide. And we went on to perform antegrade conduction assessment, and with burst atrial pacing, we could illustrate that we have evidence of pre-excitation as evidenced by a negative HV interval. Usually V should come after H, but here you can see that the reverse is true. We have a negative HV interval, which shows pre-excitation. Next slide. With continuous atrial pacing, we blocked antegrade conduction through the accessory pathway after reaching the functional refractory period, and the AV node took over, as you can see from the slide.
So the point Reuben is trying to make here is that he's pacing the atrium at progressively faster rates. So when he has been pacing at 570 milliseconds, he's having maximal pre-excitation here, and you have the his having moved and getting activated after the V. So basically you have a negative HV interval over here, suggesting presence of an accessory pathway. And when he comes to a faster rate of 560 milliseconds, the accessory pathway is blocked. And because there's anti-grade refractoriness of the accessory pathway that has been reached, the impulse has no choice but to go down the AV node. So your His gets activated before the V. And since the activation of the ventricle is happening through the AV node and not the pathway, your QRS looks different from how it looked earlier when the ventricle was being activated through the pathway, where you had a pre-excitation scene and your His becoming negative.
Yeah. So the other
Yes,
point
thank
is,
you.
can I chip in? Can I chip
Yes.
in? Yeah. Yeah. So the another point is the antigrade refractory period is of the pathway is very long. It's close to 560, 600 milliseconds. So that can explain the reason why it was not seen during sinus rhythm or baseline EP study. So it was not suspected, and later on it was only when we paced at a very slow rate of 700, we started pacing at 700, we could see the pathway, but by then we already knew that there was an accessory pathway retrograde.
Okay, thank you. This slides just demonstrate presence of an echo beat, whereby you see that the last first beat is conducted antegrade via a V node and again retrograde up. So this is just an echo beat. Next slide. Tachycardia was induced. As you could see from my RV pacing could not induce tachycardia. It's only during atrial pacing we could induce tachycardia. Next. And yes, tachycardia is going on.
This is the same slide,
No.
Reuben, showing you the induction of tachycardia with the extra at 310, baseline atrial pacing at 600 with an extra at 310, which shows a prolongation in the AH interval, as you can see. And after that,
Yes.
the impulse goes back up, and you can see the atrial activation is eccentric with the earliest activation in CS56, like we've seen earlier. So it's sort of coming down the AV node, then going up the pathway over here, again down the node, up the pathway, and the tachycardia continues.
So, here we are trying to look at the effect of spontaneous bundle branch block in tachycardia, and with the appearance of right bundle branch spontaneously, VA time did not change, giving evidence that there is a accessory pathway being involved. There's a presence of accessory pathway if you don't have change in VA time with presence of spontaneous aberrance of RBBB. Next.
No, Suresh, you want to add on that?
Sorry, I missed it. I just had a bad connection. You can add.
So, Reuben, I think the VA time was different, right?
No, it was same. It was same.
It was same here? Okay,
Yes.
okay.
Again, QR alternance is a phenomenon which is rate-rated. When you are pacing at faster rate, you have this appearance. In the past, it was being linked with pathways, but they came to realize that it's not rated mainly to pathways, but rather heart rate rated. So we just wanted to show it here. Next, we also gave his PVC, refractory PVC, to try and see if the A is pulled back. And of course, there was some wobbling in tachycardia. One might have some difficult to analyze, but you can see evidence of pulled A in that tracing, showing that there is absence of left-sided accessory pathway.
Now, I think the point Reuben was trying to make was that he's delivered his refractory PVC, And if there is a pathway and if the pathway conducts, you would expect there to be some advancement or delay. But he's not able to comment because there's a wobble in the tachycardia. So since the tachycardia cycle length is wobbling between 290 and 300 and 280 milliseconds, it's hard to comment on advancement unless you have a stable tachycardia.
Next slide. So this ECG shows a point of maximum pre-excitation. And as you can see the arrow there, I wanted to show you that in lead 2, you have a negative in lead 2, which would explain that there is involvement of coronary sinus in tachycardia mediation and pathway mediation. Therefore, one needs to do a CS venogram to rule out CS diverticulum, and we went on to do venogram. Next slide. So there was no evidence of diverticulum. We went on doing mapping. Next slide. These are catheter positioning. We mapped different locations, retrocuspid valve annulus, we mapped the septum in the different regions, and we initiated ablation. As you can see, the ablation catheter shows constant morphologies of the potentials which are not changing, meaning that we had good contact, but also evidence from unipolar lead with the steep appearance of the deflection and also a bit of ST elevation. So we had good contact and we initiated ablation. Next slide. And after a few seconds, we were able to damage the pathway, as you can see, with separation of the potentials A and V. Next slide. This shows effect of adenosine after termination of tachycardia, where we don't see reconnection. Next slide. This is ECG which was taken post-ablation, showing a sinus rhythm post-ablation. Next. So that take-home message is that in the context where we have been faced with the SVT, different maneuvers need to be performed, especially when one is not sure of what is observing in terms of capturing. As we observed, paralysis and pacing here was of showed different events from what we expected, and one should pay attention in analyzing what he finds. And here, VA intervals, issues with isoelectric time and all that helped us to rule out AV nodal response and remained with the accessory pathway and being explanation of the paradox which we are seeing at the beginning, but also the effect of spontaneous band of blanche when tachycardia is going on, and also mapping strategies when one wants to do a successful ablation, all need to be taken into account. Next slide. Yes, I would like to acknowledge Professor Sirish Snart, who was leader of this case, being assisted by Professor Haynes Lager. And also I'd like to appreciate my sincere thanks to cardiology unit for staffs, all of them from secretary to nurses, to everyone, because during preparation, sometimes you need some water to drink, to talk, to chat, and they were there for me. But also the EPC CAT team, I would like to appreciate your support. Thank you so much. And thank you, AFHRA, for giving time to present this case. It's my second month since I started EP training, and I feel that I'm very welcomed. Thank you so much for listening.
Wow. Thanks, Reuben. Thanks, John and Srinath for that excellent case. It's good to see old-fashioned EP again, in this era of pulse field ablation and AF ablations. It's nice to see electrograms again. I just wanted to ask you about the mapping of the pathway. So did you look into so you went into the coronary sinus first before you did you go into transeptally or to look on the left side, or did you ablate it in the coronary sinus?
No, we did not go to the left side. It was only from right side approach to the coronary sinus.
So you went into the coronary sinus to look for it first there. Okay.
Yeah.
Right.
And there were several points which made us map the right side first. One, actually, Reuben was showing that there was no change in the VA timing with right bundle branch block.
Yeah.
Yes.
So that excluded a right-sided pathway. So when we had a posterior septal pathway, it is very likely because had it been in the tricuspid annulus, we would have expected a VA interval increase.
Yeah.
So something like a right posterior. So we started mapping, and also the pre-excitation was very classic of posterior septal pathway described in the coronary sinus. So we started mapping the coronary sinus and mapped it to the just inside the coronary.
And when you're mapping, did you map the earliest V for the was
so
it pre-excitation?
the first actually, yeah. So there were two strategies because the pre-excitation was not so robust. We initially started with ideally in this case it would be during tachycardia we mapped the retrograde, but the tachycardia was not sustained. It was just terminating repeatedly. So that's when we started changing our strategy and went ahead with the antegrade mapping. Luckily, for during that time, it started conducting antegradely consistently.
Okay.
Shukran.
Thank you. Are there any questions? We can open it up to Prof. Mervat.
Yes, thank you, Reuben, and thank you, Roshan, for this nice case. And as you said, Ashley, fellows should understand the basic electrophysiology, the maneuvers, because it's not about ablation. It is about understanding where to go after the accessory pathway. First, I would like to ask Reuben, what kind of catheter did you use? Did you use regular catheter or did you use irrigated tip catheter?
Letters. We use regular ones. In this case.
What did you use? I didn't hear.
Regular.
Micro?
Non-irrigated?
Yeah, non-irrigated catheter. Yeah.
Okay, but non-irrigated in this situation of the CS, you will not be able to deliver high power, especially this is a small vessel and the impedance will come up and you might hit it by heat and then it will come back. So when I see this kind of accessory pathways, I get ready with the irrigated tip catheter. This is number one. Number two, when the explanation for when you pace at slower rate, you have VA time long, and then when you pace at faster rate, you get it short because the AV node is exhausted and the accessory pathway is taking over. This is my understanding of this situation. What I prefer to do is to induce the tachycardia. And before we induce the tachycardia, of course, we do V pacing, we do V exostimulation, and atrial pacing in this situation was very helpful to demonstrate the pre-excitation. If we look at the ECG, the resting ECG, there was what we call subtle pre-excitation, which is a minimal pre-excitation. But with atrial pacing close to the accessory pathway, you can demonstrate full pre-excitation, and this can help you to plan easier and quicker.
Thank you, madam. You make very, very important points in terms of bringing out the pre-excitation and pacing close to the pathway so that we elicit maximal pre-excitation and thereby being able to identify the location of the pathway and focus our mapping accordingly. So that's a very important point, madam. The other point with regards to the pacing at faster rates and slower rates. So when we talk about accessory pathways, they have usually an all or none phenomenon. So technically, the accessory pathway should be conducting, whenever it conducts at the same rate. So whether you're pacing fast or you're pacing slow, if the accessory pathway was conducting, technically your VA time should be the same in both situations. Even if the AV node fatigued when you paced faster, as against pacing slow. So essentially, if the AV node had fatigued and when we paced faster, the AV node got fatigued, and then you had only pathway conduction, then you'll have a short VA time. And when you were having conduction with the AV node conducting as well as the pathway conducting, it would still, the pathway would beat the AV node. So your VA time should have been the same in both. The paradox that Reuben was trying to explain was, why is it that when you paced faster, you had a shorter VA time? When you paced slower, you had a longer VA time. So you can't have, I mean, the only other way to say is that when you're pacing slower, the axillary pathway decided that it will not conduct. And when it was pacing faster, it suddenly decided to conduct, which is paradoxical. We don't expect pathways to not conduct at slow rates and suddenly start conducting at fast rates. If the pathway is essentially conducting both times, your VA time should have been the same. So this was the dilemma that Reuben was faced with. And then when he looked closer, he found that he had actually captured only the hiss in one situation, whereas in the other situation, he had captured the V. And hence, because he captured only the hiss, it obviously took a longer time to go to the A because it had to go through the AB node and go to the A. Whereas when he captured the V, he was able to go to the A quickly because there was the pathway to take him up.
I'll add one more thing that, I agree that out of 8 out of 10 times, we would also require a irrigated catheter. But to start with, we map with, I mean, it varies from center to center probably, but we start mapping with the non-irrigated catheter, just for the reason that non-irrigated tip, the electrode is smaller and it has much crisper electrograms. When you're mapping something like a pathway, that non-irrigated is much better in terms of electrogram quality. And we start with that. Maybe 2 out of 10 times, if it's just outside the CSOs in the actual postoccipital, we'll get away without an irrigated catheter. But I agree that if it is deeper in the coronary sinus, we'll have to switch to an irrigated catheter. Yeah, we always keep that ready, and we just keep it as a backup. In this case, we were lucky that we got it without them.
So that was a very important point you made, Madam Professor Mervat, about using irrigated catheter for ablations in the coronary sinus or the veins, because it helps us to deliver adequate power. So I think it's important for the fellows to be cognizant of that often there is difficulty in delivering adequate powers in the venous structures, and an irrigated catheter helps. So thank you so much for that point, Madam.
Okay.
I don't see any other questions on the chat line. And the 3D mapping, do you guys use it selectively for WPWs, or who do you decide to use 3D mapping and non-3D mapping?
So we usually use 3D mapping when we have a patient who's been tried elsewhere, failed, and has come back with a recurrence. So that's a kind of situation where we consider using 3D mapping, but otherwise traditionally we don't use 3D mapping for our accessory pathway cases. And then of course, sometimes you will have 3D mapping being used for another case and an accessory pathway case following that case, in which case we use the 3D technology because it's available. Because essentially the finance is what decides it. So most people struggle to afford 3D mapping.
Yeah,
I agree with you, Dr. Roshan. You can ablate accessory pathways a very short time if you understand the ECG and the mechanism, and you do some maneuvers, then you can go and hit it and make proper measurements. You have to have very good ECG recording and intracardiac in the room. You have to work hard to get rid of any interference. Grounding of the machine is very, very important so that you can depend on the signals to get accessory pathways done. We don't use 3D unless we have failure of accessory pathway ablation in 2 sites. If I fail in one, then we have to do it 3D. Yes, and this is because this is money and time. Also remember that this 3D, the connection, the magnet, if you are not having all 3D cases running one after the other, then the connection will take at least 30 to 40 minutes connection and checking and so forth. So if we are in Africa, we are not in Europe, we are not in America. In America and Europe, they do all cases, even AVNRT by 3D, and this is why, if you want the truth, because they are get paid more when they use 3D. So they said, why should I use? And of course, they are afraid of the fluoro and stuff like this.
Very good points, madam. Very good points.
Yes, yes, yes.
I agree with you fully.
Good. I think those are all the questions today. It was I think it's almost 6 o'clock South Africa. I don't know. Thanks. I think India, it must be close to 12 o'clock. So I think
No, it's
probably
9:30.
Is it 9:30?
Ashwin.
Okay, sorry. Okay. But I think, yeah, I mean, I think those are all the questions we have. So
Yeah, just a shout
yeah.
out to the fellows if they've understood everything. And is there any doubt, Dr. C and anybody else, any doubts?
Dr. Arana from Egypt, if you have any question.
We are happy to reshare the slides and
Dr.
go through
Mahmoud
it if you have
Balata.
doubts.
It was a very
no,
nice case, Dr. Melvin.
Thank
Thanks
you.
for
Thank
the
you.
case.
That was very interesting. Many thanks. I don't have any questions.
Ahmed Farid
no,
from Palestine. Ahmed Farid from Palestine. Mohammed Balata from Germany. Okay. Okay, they don't have questions. There was a question in the chat, which was expecting Mahayim to explain the difference in the VA time with pacing from the ventricle. By the way, I will answer this question. Mahayim does not have retrograde conduction. Mahayim is a decrementally conducting antegrade atriovascular pathway. So that was a question in the chat, but it was deleted or by someone.
Okay.
Yeah, so this session's been recorded, and I think it will be for those who've maybe just missed some of the points. I think we will share this presentation with
I would
everybody's
like
permission.
also to announce about the abstract submission and the case presentation submission to the cardiorhythm AFHRA. We already sent it to all groups. Please share your cases. Please share your abstracts. By the way, the abstracts will be published at HRSO2 journal this year, like what we did last year. So please share your experience with us through abstracts or through cases. And Ashley is one of the committee. We wish that you can join us in Kigali on the 18th of September till the 20th, so that all African fellows and consultants will share their experience together.
Yeah, thank you.
Okay.
Thank you.
Many
Thanks, everyone. Thanks
Many
for attending this evening. Until it will, I think next week, I think the next month, maybe Cape Town's presenting. So we're looking forward to that. Okay.
Okay.
Good evening, everyone.
Good evening.
Bye-bye.